So some of the conclusions that we've drawn from our small-scale testing and the use of a registry is that the preliminary small-scale testing of PEXIS has led us to conclude with substantial confidence that the use of a registry to gather client quality improvement and outcome data is doable. To me, that means it's viable, we can do it in my lifetime, it's practical, efficient, and cost-effective. As a small county with limited resources, that's critical for us. And you don't have to have a PhD or a master's in statistics to do this. The use of turnkey reports for fixed data elements in the registry format is a practical, easily usable quality improvement approach for tracking, utilizing, and reporting client outcomes at the client level through program, county, even state and federal, with shared outcomes or a crosswalk between it. The data contained in the registry is exportable. The fixed data elements have significant potential for timely outcome measurement, evaluation, and or research at all system levels, and is HIPAA compliant. The use of client level data is very promising for communication with the primary care setting and integration of healthcare. One of the things that we're going to be testing in the near future is giving our primary care healthcare clinic access through VPN, which we have set up and ready to go, access to the registry that we can do medication reconciliation, we can share lab tests, we can share the physical health care measures that we collect. They can input theirs. Doesn't cost them anything, doesn't cost us anything more. And I think that that's a critical point for all of us as we look at integration of care, is some way to communicate that. If I decide to decentralize and place my staff in the rural health clinics, which we may well do in the future, they can VPN into our practice management system, do their recording, monitor their practices, we can monitor them, and I can do it within a few months of implementation. Most of it's ready to go for us now. So what we've committed to doing is trying to standardize the lessons that we've learned in creating reports and in setting it up and the training that's necessary, which is much less than the electronic health record, and document meaningful use in a very timely way. So I kind of wanted to leave it with this. You know, we can carry on talking about what we can't do right now. I think we have to talk about what's doable right now. We can talk about how we want to be independent and autonomous, whether we're an agency and requiring oversight, or we're a county that wants to do things our own way. But I think that we're on the cusp or the precipice of so much change that we've got to figure out how we can agree upon the common things that we need to agree upon, how we can either crosswalk or select a way of communicating with each other and sharing outcomes and aggregating outcomes, or we may well not exist in the future. I think it's that simple. So kind of my appeal is let's get it together, let's make some hard decisions, and let's move forward with what we can do and not wait for the hope of tomorrow.